Dr. Mazen Kherallah, he needs no introduction. That's it. Thank you. All right, I'll do the formal introduction. Dr. Mazen Kherallah completed his internal medicine training at University of Chicago, followed by fellowships in infectious disease at University of Chicago and also Medical College of Wisconsin. He later went on to pursue fellowship in critical care at Wayne State University. Over the past 29 years, Dr. Kherallah has held various clinical and administrative roles, including chairman of critical care department in King Faisal Specialist Hospital in Jeddah. He currently serves now as associate program director at Insight. He's also the associate professor at the University of North Dakota and medical director at critical care services at Stanford Health. He has authored multiple publications and notable contributions in his field. Beyond medicine, Dr. Kherallah has extensive expertise in computer programming languages, artificial intelligence, cryptocurrency. He also hosts an educational website aimed at providing global access to high-level critical care knowledge. Please join me in welcoming our Associate Program Director, Dr. Mazen Kherallah.
Assalamu alaikum. Thank you very much. Appreciate this. So I see Dr. Shakur here, and if you have myocardial infarction, STEMI, he would be pushing this patient to the cardiac cath, and the window is shortening year after year. I'm not sure if it's 60 minutes or less now. Similarly, if you have patient with stroke, you have a 3-hour window. You want to start the now actually the thrombectomy as soon as possible. Unfortunately, sepsis did not get this level of attention till the early 2000s. And this is what I'm going to be concentrating on, the first 1 hour after recognition of sepsis. But the agenda for today would be some quick definitions of sepsis, and then we'll talk briefly about the Surviving Sepsis campaign and the different bundles that evolved throughout the years, and then early recognition, and we'll detail on the 1 hour bundle elements. And of course, as usual, everything is going to be evidence-based. So sepsis is a spectrum, and it is actually continuation of a process that starts with infection. And infection is defined as the presence of microorganism in a tissue or mucous membrane or an organ that usually does not have organisms. SIRS is systemic inflammatory response syndrome that may be present in conditions other than infection. But if it is associated with infection, according to the old terminology, we call this sepsis. So sepsis is infection, whether it's confirmed or suspected, plus the SIRS criteria, 2 out of the 4 criteria. Now, if that sepsis is associated with end organ dysfunction, and I'm not saying failure, dysfunction, at least one organ out of the multiple organs that we have in the body, at that time we have defined severe sepsis. If that end organ is vascular collapse and the patient is hypotensive and it is refractory hypotension, at that time refractory to fluid boluses, and we require to use vasopressor, at that time we define septic shock. And if you want to depict that on a diagram like this, if I have all patients with infection here, and I have patients on the other side where they have systemic inflammatory response syndrome, this syndrome can be, of course, associated with different etiologies other than infections, such as burns, trauma, organ rejection, or any other cases of SIRS. However, if it is associated with infection, based on this old definition, this is the intersection between the 2 circles, and this is where sepsis resides. If we have end organ dysfunction, it would be a category inside sepsis. And of course, if you have a bloodstream infection, it does not necessarily tell you that the patient has severe sepsis or septic shock, because it could be present in any of those categories. And septic shock will be a circle inside that severe sepsis category. Now, as of 2016, things have changed. There's a new definition for sepsis, which is sepsis 3. And I don't like this definition because it's more physiological definition. They define sepsis, I can't read from here, as life-threatening organ dysfunction caused by dysregulated host response to infection. And septic shock still is subset of sepsis where the mortality is higher than sepsis. But the clinical definition for this would be hypotension requiring the use of vasopressors to maintain a blood pressure of 65 and above. And of course, it should be associated with evidence of hypoperfusion, mainly evidenced by lactic acid 2 or more of the normal value. So according to the old definition, sepsis is SIRS plus suspected infection. Now, sepsis, the term sepsis, is suspected infection and organ dysfunction. So we do not utilize sepsis anymore for patients who do not have end organ dysfunction. But septic shock is still the same definition. Now, they eliminated the SIRS criteria and they introduced the SOFA score. And they introduced a quick SOFA that does not rely on the use of labs. So you can see if you have 2 out of 3 quick SOFA manifested by at least 2 of this, either systolic blood pressure less than 100, altered mental status, Glasgow Coma score less than 13, respiratory rate more than 22. And when it came out, actually, quick SOFA was practiced very commonly in the clinical settings. And we ended up identifying more patients as sepsis than what they are actually representing. And that, if you take a look on the new definition, is similar, but now sepsis is end organ dysfunction and shock is within this. The introduction or the launch of surviving sepsis guidelines or campaign started in 2002. And that was actually in Barcelona. Throughout the years, you can see that they released multiple guidelines. These guidelines will have directions to clinicians based on the available evidence before the release of the guidelines. And they addressed every element of sepsis management, including hemodynamics, respiratory ARDS, infection, antibiotic utilization for those patients, renal replacement therapy, and all the other elements of sepsis management. With each guidelines, they released bundles. And the first bundles that we had was in 2004 with the initial guidelines. As you see here, we used to have 6-hour management bundle and 24-hour management bundle. Throughout the years, this evolved into 3-hour. The 6 hours now became 3-hour management bundle, and the 24-hour became 6-hour management bundle. They released the new guidelines in 2008 and 2012 and 2016. In 2018, we evolved into 1-hour management bundle only, and that's what I'm going to be talking about here. This is a landmark article that was published after a mandate for all emergency rooms in New York, that they have to apply the 3-hour bundle. This is in 2017, I believe, yes. And it included close to 50,000 ER visits or patients who were coming to the ER at 149 hospitals. And they looked at the outcome based on the implementation of the 3-hour bundle. And you can see here, for those patients who had delayed implementation of the elements of the 3-hour bundle, they had increased mortality. Similar things that noticed with antibiotics, but it was not noticed at the same level with fluid administration. And in this article, every 1-hour delay in implementation of the 3-hour bundle was associated with 4% increase in mortality. So if we're going to have increased mortality with any delay of therapy after recognition, that means we should early recognize those patients. The earlier you recognize those patients, the faster you can implement the 1-hour bundle. And of course, you're going to see patients coming from home. So it depends on when did the patient seek medical attention. He may come to you already late in organ damages and dysfunction, which might affect his outcome. But our job is to detect those patients as early as possible when they come into our emergency room. And if they are already in the hospital, we need to have early warning system that will alert us that this patient may have sepsis. And we rely on our own judgment. Multiple warning systems have been used, including the Muse, the SIRS, and the QSOFA. I'm not going to go through the details of this, but multiple publications showed that if you cannot rely on one system alone. You have to utilize your clinical judgment at the bedside, utilizing multiple clinical findings and scores in order to define those patients with sepsis early enough so you can institute the therapies needed for those patients. You probably noticed that with Cerner, you have a tool that alerts you that your patient may have sepsis. This tool is based on structured data, meaning when the nurse put the heart rate, the respiratory rate, the WBCs of the lab, the system looks at this data and give you a warning. In one study that included, in a meta-analysis that included 22 different studies in 19,000 patients, showed that implementation of early warning system based on the medical record is actually associated with faster time to fluid administration by 43 minutes. Faster time for blood cultures. You can do blood cultures faster for those patients. Time to antibiotic administration decreased by average of 34 minutes. And time to lactate measurement is improved by 15 minutes in those patients who have, in the systems they have, this warning systems in them. More importantly, the mortality rate improved. You can see here that the mortality rate is decreased and the heterogeneity among those different studies is not that bad actually. So this is relying on our EMR to alert us that our patients may have sepsis. Now we can introduce also artificial intelligence, where not only looking at the structured data, but also looking at your notes, your admission notes, your progress notes. So this is non-structured data. AI can read that, combine this with the structured data, and then give you a diagnosis based on algorithm, whether the patient may have sepsis or not. And by implementing this system where they can use the EMR plus the AI to detect, to early recognize those patients with sepsis, you can see that this system did better than any other individual scoring system that we have. Whether we can detect it at 4 hours, 6 hours, 12 hours, or even as early as 48 hours prior to acknowledgement of EMR or the physician attention. And this is comparing the early recognition of sepsis This is our AI system at 48 hours compared to physicians. You can see whether it is 24, 12 hours, 6 hours, or 4 hours, the AI system did better than physicians in recognition of sepsis. So with this introduction, I'm going to detail in the elements of 1 hour bundle. How many of you know all those? You must all know actually all the elements of bundle. So we're going to just look at the evidence. So we have only 1 hour to complete all this, starting with measurement of the lactic acid. And then we need to obtain blood cultures prior to antibiotic utilization. And then we need to administer broad spectrum antibiotics and give the fluid bolus and apply vasopressors. Very simple. So let's look at measurement of lactic acid. We knew that lactic acid is an indicator of tissue perfusion long time ago, and this is actually in 1964, 1 year after I was born. And those patients who had lactic acid more than 3.5 had mortality rate at date number 10 at 30%, compared to mortality rate 30% for 3.5 or above, compared to lower mortality rate for those patients who had lactic acid less than 3.5 millimole per liter. Lactic acid clearance is associated with better outcome. And that's why we asked you to repeat lactic acid. We want to see whether the patient is responding to your fluid and antibiotics. You should be able to decrease lactic acid by 20% every 2 hours if the process is actually been controlled. And you can see here that those patients who had lactic acid clearance more than 10% had a better outcome compared to those patients who had lactic acid clearance less than 10%. Not only that, lactic acid helps you to identify those patients with occult shock. How many times you have a patient with blood pressure of 120, 130, but the lactic acid is 4 or 5? Those patients usually are hypertensive at baseline, not well controlled. When they decrease the blood pressure by 20% from the baseline that they had prior to admission, they go into shock. And you can identify those patients based on the lactic acid. So that's why we mandate lactic acid in all septic patients to identify those patients with occult shock. And you can see here, this is systolic blood pressure more than 90. And look at the mortality. This is lactic acid. Those patients with normal blood pressure, if we're going to look at the absolute value, but mortality rate is increased for those patients. You can see mortality rate at 10%. Of course, more hypertensive you are, more the elevation of lactic acid, the mortality rate is higher. And if you do not have possibility to measure lactic acid in certain resource limiting settings, well, it's been compared with the capillary refill time. And the results are similar, whether you do lactic acid clearance or you rely on progression of the capillary refill time. So that's in regard to lactic acid measurement. We measured it on admission, and we repeat the lactic acid in 3 to 4 hours. We should see at least 40% decrease in the lactic acid. The second element is obtaining blood cultures prior to institution of antibiotics. It is very important because if we do blood cultures in patients after receiving antibiotics, the rate of positivity of blood culture is much better than if we do it after receiving if a patient did not receive antibiotics, the rate of positivity is much better compared if the patient received antibiotics. 50% compared to 28%. And now, I'm not sure if you have it here in the hospital. What we rely on, not only the detection of positive blood cultures, but also we look at our rapid diagnostic testing. If the blood culture turned out to be positive, and if we have rapid diagnostic testing, we can identify the gene that is responsible for drug resistance. And if we combine this with our positive blood culture results, you can see that we can improve, number one, time to optimal therapy. This is rapid diagnostic testing in addition to antibiotic stewardship program. If we have this compared to only blood cultures, we can improve time to optimal therapy. Number one, length of stay, you can see, is much better compared to any other combination. And number three, mortality is improved if we have early detection of the specific organism by our rapid diagnostic testing. And this is widely available right now in the States, and you should have it here too. The third element of this, antibiotics. Now, in terms of antibiotics, you can see this study is back in 2006. And you can see if we may have a delay in institution of our antibiotics. At that time, almost 50% of patients did not receive antibiotics till 5 or 6 hours. Now, if you correlate this with the mortality, you can see decreased survival rate in those patients if we delay antibiotic therapy for those patients. So that's why we seek to start those antibiotics as early as the first 1 hour. And when we say first 1 hour, that means as soon as possible. If we can do it in the first 10 to 20 minutes would be perfect. All what you need is just check lactic acid and do blood cultures, then start antibiotics. And this is another study also showing you, this is from 2014, showing you that probability of mortality is increased based on any delay in the antibiotic administration for those patients. And this is the graph from the same study showing increased mortality if we delay antibiotics. Now, the Surviving Sepsis Guidelines or campaign gives specific instruction on how fast, because now when we say give antibiotics to everyone, we're going to end up giving more antibiotics than what we should do for our patients. Some of those patients whom we're identifying as sepsis, they are really not septic, not infected, do not need antibiotics. So now they adjusted this in the latest guidelines, and this is supplementation of to the 2018 guidelines, where we look at, number one, probability of infection or sepsis, and number two, whether the patient is in shock or not. Now, if you have a patient in shock, give antibiotics within 1 hour. So patient with hypotension, you're suspecting infection, your suspicion is probable, or it's possible, which is lower degree, you would give antibiotics immediately. If the patient is not in shock and your sepsis is probable, you also give antibiotics as soon as possible. However, we say it's like, I'm not sure if the patient is infected, he's not in shock. You can wait for the first 3 hours to complete your workup. Do cultures, complete any imaging studies needed to be done, ultrasound, everything, and then come back to that patient and decide. So this is what the Surviving Sepsis campaign recommends. Now, there's a study that was just published a few months ago showing that, is this really helpful? Is this representing the reality? So this is real-world implication of these guidelines. And they apply the same principle here, but it is all based on AI. And they found out that those patients with probable infection and shock had the highest mortality, 17%. And those patients who had possible infection, no shock, had the lowest mortality, 2%. Those patients who had no shock but probable infection had a mortality of 3%. And you can see if you have shock and whether the infection is probable or possible, your mortality is 12%. So still, I think this emphasizes that those guidelines that were given by the Surviving Sepsis campaign are valid. And we should apply to any patient who is hypotensive in ER, whether you suspect infection as probable cause or as possible cause, you need to give antibiotics as early as possible. But if the patient is not in shock and your suspicion for infection is only possible, you can take your time for the first, instead of 1 hour now, we have 3 hours to give those antibiotics once you confirm that the patient has sepsis. The fourth element is the sepsis bolus. And this is all started by the early goal-directed therapy by Emmanuel Rivers. This is a landmark study in critical care. It is a single institution at Henry Ford in Detroit, and included 2,000, I don't have the number of patients here, but around 2,000 patients. It's a good study where they compared early goal-directed therapy targeting, given number one, fluid. But we used to do central line to target a CVB above 8, and then give vasopressors to target mean arterial pressure above 65, and then measure the central venous O2 saturation and use RBC transfusion or dobutamine infusion to target levels of more than 70. So you can see that you really need central line in order, and most of the time arterial line, in order to implement this early goal-directed therapy. But that resulted into a dramatic decrease in the mortality. For early goal-directed therapy was 30% compared to usual care, 46%. And the number needed to treat is only 7 patients. By doing this early goal-directed therapy, it was published in New England Journal of Medicine. This had changed the practice. We were like so crazy about putting central lines like right away in those patients, targeting those elements that we need to achieve, more aggressive in the fluid and resuscitation of those patients. Then we have 3 different studies that were published around 2015, 16, 14 or 15. Those, one study is in New Zealand, the other one is in the US, and then one in England. The process, the arise, and the promise. They compared early goal-directed therapy to usual care, the same study that Emmanuel Rivers did. However, in this study, Emmanuel Rivers found 46 versus 30%. And I put the Apache score because they are different population. However, they compare to usual care in each of those studies. No difference in mortality between usual care and early goal-directed therapy. And this is the Kaplan-Meier curves. There is no difference between the usual care and the early goal-directed therapy. However, usual care has changed. Usual care in 2000 did not include aggressive fluid management. With all those changes in the studies, usual care is now including fluid management as early as possible. They put these 3 studies together, and they looked at the fluid that they received prior to randomization. And you can see that in the 3 studies, process, promise, and arise, the fluid was around 30 ml per kg of each of those studies. And they compared the fluid that patients received, the median IV fluid in early goal-directed therapy, 2,000 patients, and in usual care. And you can see the amount of fluid that they received in the early goal-directed therapy is similar to the usual care in terms of the initial fluid bolus. And this is how, and this is showing that Kaplan-Meier, this is all the studies together, no difference in the mortality. This is how the sepsis bolus was born. And now when we say give the sepsis bolus, that's what we mean. 30 ml, this is based on these 3 trials in addition to the early goal-directed therapy by Emmanuel Rivers. Now, it was challenged Do we really need to give the 30 ml per kg? Unfortunately, the two studies that were designed to answer this question did not actually give restricted flow. The first one is the Clover's trial. It was actually meant to test this hypothesis, whether we really need a 30 ml per kg or not. However, you can see the pre-randomization fluid received was between 1 to 3 liters. Ended up actually looking at follow-up fluids after that initial fluid bolus. Those patients who received aggressive fluid management did not have better outcome or mortality compared to restrictive fluid strategy. We're using vasopressors here earlier than in the fluid predominant approach. So no difference in terms after the initial bolus, whether you restrict the fluid or you liberal in the fluid, there's no difference in mortality. The classic trial is another trial was designed to answer that question. The initial bolus is only 1 liter. And you can see here the median fluid in the ICU was much higher in the standard fluid compared to the restrictive fluid. And the 90-day mortality is not different. So what we learned from this that the initial fluid resuscitation is the most important element of fluid replacement in those patients. After that, restrictive strategy will give you the same outcome as liberal strategy. And the way this is my own approach. The way I do it is I need two elements together. I give the 30 ml per kg IV bolus. However, if I have the tools to test whether the patient can respond to my initial fluid bolus in the ICU as an intensivist, I may give less than 30 ml per kg. If I don't have the tool or the skills, at that time, just give the 30 ml. By the way, even patients with renal failure and congestive heart failure, they had better outcome when they were given the 30 ml per kg. Most of the time, patients got CHF history, I'm not going to give them the 30 ml. Those patients did worse. So what I rely on is two components. First, I need to show that patient has hypoperfusion. And number two, I need to show if I give the fluid, patient is going to respond. And that is actually based on the following. Hypoperfusion lactic acid. If the lactic acid is more than 2 millimole per liter, that's an indication for me that the patient is hypoperfused. But you can also use the CO2 gap, the difference in the CO2 between artery and vein. Of course, the CO2 in the vein is higher than in the artery. But if that gap is more than 6, that's an indication of hypoperfusion. We don't use this often. And if you have a central line and you can measure the central venous, if it is above 70%, it may indicate that the patient is hypoperfused. However, as you see, in reality, all what we rely on is lactic acid. And then you need to test for responsiveness. And this is based on the Frank-Starling curve. I do not know the slope of the curve for my patient. What I need to do is 2 points. I need to move the patient across the x-axis, and I need to see the results on the y-axis. So I can move the patient from this point to this point by giving him fluid bolus. But I can do this without giving fluid bolus if I rely on passive leg raising, or if I look at the changes in the intrathoracic pressure if the patient is on the ventilator, or even if the patient is not on the ventilator, but the numbers will be different. If I change this, if I change the CVB from this point here to this point, which is the preload, I can monitor the output, which is the stroke volume. And that is based on multiple indicators. I can look at the systolic stroke volume variation, systolic blood pressure variation, pulse pressure variation, heart rate variation, CO2 variation, or aortic blood flow variation. If I have these two components here, I can determine where my patient does reside in terms of this curve. Is he on this part of the curve where you can see a change in the preload? It's going to give me a remarkable change in the stroke volume, which is usually more than 12%. Or is my patient is on this side here, where a change in the preload is not going to give me a good change in the stroke volume. So the algorithm that I follow is the following. I detect whether there's perfusion or not. You may have static volumetric measures, do not mean much, or whether those are volumetric or pressure measures. I can rely on those, but mainly I look at the dynamic measures. And in a recent study that I don't have here, just like 2 weeks ago, they showed that the most sensitive indicator is change in the stroke volume. And we can look at this by the passive leg raising, where you can mobilize a fluid. And this is what we mean by stroke volume variation. So this is the stroke volume. This part is stroke volume. You can see here, stroke volume is increasing and decreasing. You look at the maximum, minimum, you relate to each other, and then you get the ratio. Similarly, you can look at the pulse pressure, or you can even look at the systolic blood pressure, which is the pulsus paradoxus that you learned in medical school. And sometimes you don't really need to do anything. Take a look on this patient here. It's inspiration, expiration. You see variation? This patient needs fluid. Very easy. And then you can put the ultrasound, and you can see this. You don't need to measure anything. Collapse here, expanded here. This patient needs fluid. And you can raise the legs by 45 degrees for 90 seconds. And then you look at different variables here. You can look at the pulse pressure, whatever you have. You can look at the systolic blood pressure, the heart rate. If you have the echo, you can put and measure the VTI. And VTI is very easy, actually. If you learn the basic skills in bedside ultrasound in ICU, you'll be able to measure that very easily. You see a change in the VTI here. That's the response to fluid. It takes 2 minutes, 3 minutes, actually, to do this. And also, you have a patient on the ventilator, hold the expiration for like 15 seconds. And expiratory hold. Pressure is the minimum. Venous return is the maximum. So you should expect to see an increase in those outcome measures. Any increase in the cardiac output more than 5% is an indication that your patient may respond to fluid. Take a look here. This is the hold and expiratory hold. You can see 5% increase in, I can't read this, aortic pressure it looks like, and then we get fluid that improved. So very simple tools. The last one is vasopressors. Vasopressors now need to be started early. And of course, the only vasopressor we care about here is to start as initial vasopressor is norepinephrine. And you should know it has more alpha than beta, but it does have some beta stimulation. And any delay in administration of vasopressor is associated with increased mortality. You can see here, this is the delays in terms of hours for starting vasopressors. And you can see the increased mortality alongside. Norepinephrine has multiple hemodynamic effects. Not only increased cardiac output in early stages, of course, of sepsis, it increases also the venous return. So it increases the preload to your patient. And at the same time, of course, you would expect that heart rate is increased and afterload is also increased with vasoconstriction. The initial study that showed difference in terms of outcome was the SOAP2 trial that compared dopamine with norepinephrine. And you can see that 28 mortality was not different. However, rate of arrhythmia was higher with the dopamine compared to norepinephrine. And then multiple studies came out, and this is in 2015. We have a meta-analysis. Not a single study alone was able to show that mortality is better with norepinephrine compared to dopamine. However, when they combined all those studies together, you can see that mortality was improved when we use norepinephrine compared to dopamine. And the mortality is decreased by 11% for those patients. And you can see the heterogeneity is 0%. Those studies were actually very similar to each other. And norepinephrine was associated with reduced all-cause mortality. Absolute risk reduction was 11%, and number needed to treat was 9%. And this is how now we say norepinephrine is the initial vasopressor that you need to use for those patients. But not only that, you should not delay this anymore. We used to say, give the fluid, see the response, and then start the norepinephrine. A delay in comparing early versus delayed administration of norepinephrine is associated with worse outcomes. So we need to start this as soon as possible to our patients. In this study, delaying it more than 2 hours was associated with much higher mortality compared to giving the norepinephrine in the first 2 hours. And the reason is simple. Those patients have vasodilatation. They need more fluid. If I don't vasoconstrict those patients, I'm going to end up giving them more fluid to maintain the blood pressure. Fluid administration is going to give you consequences and probably worse outcome. Constrict the vessels early, give fluid administration at the same time, those patients have improved outcome. And this is the vasoactive agent management based on the surviving sepsis guidelines. Not only that, they recommend that you do not need to put a central line to start norepinephrine. You can utilize norepinephrine through peripheral line for the first 1 hour. Now, there are many studies actually, it shows that it is safe as for norepinephrine as high as 0.3. But usually in our hospital, we do not go above 0.2 microgram per kg per minute of norepinephrine through peripheral line and not for longer than 24 hours, worried about extravasation and skin necrosis for those patients. But if you want to challenge this, you can actually challenge it in multiple studies. The take-home message is very simple. The 1 hour bundle includes, number one, check the lactic acid. If it is elevated, recheck it in 3 to 4 hours. Number two, obtain blood cultures prior to starting antibiotics. Number three, administer antibiotics. It has to be broad and appropriate, not cefazolin for a patient who's coming from nursing home. Number four, administer intravenous fluid. Sepsis bolus is 30 ml per kg in the first 1 hour. You can decide about further fluid management based on the responsiveness and the evidence of hypotension. And the last thing, apply vasopressor, norepinephrine, very early, as soon as you detect the patient is hypotensive. After you start the fluid, and you can start vasopressor at the same time. With this, I think that's all what I have. If you have any question, I'll be more than happy to answer it. Yeah.
And it also tells them only if the lactic acid is above 4 is okay to administer the same 30cc with the lactic acid of 2.5.
So thank you. So the definition of sepsis or septic shock is lactic acid more than 2. The surviving sepsis guidelines, the 1 hour bundle, lactic acid more than 4. However, I'm very aggressive in giving fluid to anyone who has lactic acid more than 2. And the initial bolus, the 30 ml, based on your initial assessment. In the first 1 hour, you can give it 30 ml per kg means around 2 liters per someone who's 70 kilos. Okay, by the way, we do not know whether we should go with the ideal body weight or the total body weight. That nobody has looked at this. Somebody who's like 400 kilos, how many liters is going to get? If you go with 30 ml per kg, okay, it's going to be 12 liters. All right, so and that's why you need to give fluid and be able to assess the response. If you have a way to assess whether the patient would be responsive before you give the fluid, like what I mentioned, that would be optimal. Again, that fluid bolus, if you don't have that capability to assess fluid responsiveness and hypoperfusion, just give the bolus that is determined in the literature.
And do we measure the repeat lactic acid if the like to assess the to see if there is hyperperfusion still there or not? After 4 or after 2?
After how many hours?
Let's say we give 30cc.
Yes.
And the lactic acid is 3.
Lactic acid is first. You have a lactic acid of 3, you get the 30 ml, and then you repeat the lactic acid in 3 to 4 hours. Yes, in 3 to 4 hours of the initial lactic acid, because essentially, this is very quick here. So those elements, they should be in this order. You take lactic acid at the same time you do in the blood cultures. So this is and you order antibiotics. You actually end up giving fluid before antibiotics because it takes time for the antibiotics to arrive. But fluid is readily available. And then usually I would see if the patient responds to initial 500, which is given like in 10 minutes, and then blood pressure is still low, give vasopressors. So this should actually, the whole cycle here should be in 30 minutes.
Can you also mention about the SARS and the Q's profile? You mentioned the one study that is more like, the Q's is more better. But I think most of the studies, no one is to use a single tool, not sensitive yet.
Yeah.
So my question would be, can we use 2 tools for levels?
Or 3 tools. Yeah.
And if you have to follow the patient, can we use them interchangeably? Or if you have to use SARS, you have to use SARS and the various.
Well, let's just put those tools under clinical judgment. Utilize whatever tools you have available in your hands. You have the QSOFA, the full SOFA, the source criteria, everything. They're all the same, actually. Look at the parameters. You will see heart rate, blood pressure. Those are the parameters of patient who's septic, who has a low perfusion. So those parameters, no matter how you want to combine them, if you have a collective ability to combine those things together, the elements, and then you put your clinical judgment based on this, and then you administer the fluid boluses based on that clinical judgment. It doesn't matter whether you use 1, 2 together, you need to utilize those for the best of your clinical judgment.
One question I had was, it looks like you mentioned that norepinephrine is becoming kind of the preferred vasopressor. We see a lot of like phenylephrine use here. A lot of times, maybe the patient's coming from the OR or a different setting, and I understand, phenylephrine you can use in a peripheral IV, so it's a little easier, I guess, to get started. But as a cardiologist, we actually really don't like phenylephrine. It increases afterload significantly. It does very little to help with cardiac contractility or other parameters. So, is there literature on phenylephrine and whether or not it should be used in sepsis? Because it seems like if we can, you mentioned you could even do a peripheral IV for 24 hours with norepi, we should be defaulting to norepi and using very little.
And that's the way it should be, actually, yes. There's enough in the literature to show you complications associated with phenylephrine, including ischemic limbs, because of the strong vasoconstrictive capability of phenylephrine. In fact, the way I look at it is you're improving the blood pressure, but you're not improving the perfusion for the organs. And that's why it is not preferred. And let me add something else. Even if the heart rate is increased, even if your heart rate, because sometimes like my heart rate is 120, so I don't want to use norepinephrine because norepinephrine may increase the heart rate. They looked into this and they found that heart rate, of course, if it is 140 and above, you would be worried. But for those patients with heart rate, I don't remember the exact heart rate in that study, but 120, 130 should not be a reason why you should not start norepinephrine for those patients. Start norepinephrine, and of course, if the heart rate became 160, that's a different story because you need the diastolic period of the heart in order to be able to fill in the left ventricle and be able to have a good stroke volume. So the preferred agent is norepinephrine. If the patient does not respond to norepinephrine, what's the second one? Vasopressin. Okay. If the patient is tachycardic at 140 or 160, and you don't want to start norepinephrine, the answer is no. The second choice after norepinephrine was vasopressin. So why I'm not using it as a first choice? Vasopressin. Okay. Vasopressin. Okay. So again, the patient is in, you need to differentiate if the patient is in AFib because of sepsis, or this is a long-standing AFib with RVR that the patient has because of the critical condition. So improving sepsis, fluid bolus may actually improve. And in fact, those patients, if the heart rate is rapid, I may decrease the heart rate a little bit. And now we can talk about this. There are a lot of studies looking at decreasing heart rate in patients with sepsis with esmolol. And there's a meta-analysis that recently published showing that outcome is improved, but still not the standard. It's not recommended yet by the Surviving Sepsis campaign. Yes.
Between, when we do fluid resuscitation, with initial doses, what kind of fluid would you prefer
Oh.
between NS, LR, or plasma line?
Okay, thank you very much. So we don't have a concrete answer to tell you mortality is better with LR compared to the normal saline. However, we have enough evidence to show mortality is less with LR compared to crystalloids, normal saline. So that's what we prefer. There's a designed study called the PRECISE study. It hasn't launched yet. It's a multi-center trial in the US looking at LR in a specific population, and they have 4 groups, A, B, C, and D. The group D, patients who are hypotensive with shock, those patients benefited the most out of LR. And they are looking for the benefit for those patients with LR. In other words, just to make it simple, use LR. We don't have a strong evidence, but there's an inclination that mortality is less or outcome is better with LR compared to normal saline. Any other question? Go ahead, yes. Tariq.
Just one question, please. Sometimes we have a call from the pharmacy that some medications do not go along with LR, we need to switch to normal saline. So if you can ask about the medications, including the last ones from the pharmacy that do not go along with LR.
So those patients usually have 2 IVs, not only one. So if a medication is not compatible with LR, you don't admit a patient to the intensive care unit with 1 IV only. You need to get 2 IVs, so you have if it happens that you have 1 IV at that time and the pharmacist tells you that it is not compatible, at that time you can change the normal saline. It's not a big deal. As soon as you can done with that medication, change back to LR.
The second question is that most of the time this cycle will be done by the ED doctor before calling us. But like what if we have the call, we check on the patient. LR is not like ordered, or let's say LR lactic acid is still high. Do we prefer giving boluses again? Or do you prefer the continuous IV fluid?
So, are you talking about beyond the first 1 hour?
Yeah.
Okay. Any further fluid is dependent on 2 things. Number 1, hypoperfusion, lactic acid elevation. And number 2, your clinical judgment, whether the patient may respond to fluid or not, based on what I talked.
So let's say lactic acid went down from 5 to 3.5, still high.
Within
1 hour.
That's great. All what you need is 20% every 2 hours. There's a half-life for lactic acid too. It's going to be cleared by the liver, but it takes time. You should not see that lactic acid is 4, went down to 1 in 2 hours. So it goes down by 20%. The minimum that you would seek for is 20% in 2 hours, 10% every 1 hour.
If the patient is on multiple pressors, how we de-escalate? How we
Okay, excellent question. Thank you. Yeah. So, multiple pressors. Let's just look at the order. We start with norepinephrine. When do we add vasopressin? When we get to 0.2 to 0.3 microgram per kg of norepinephrine. Then vasopressin added. Do we escalate vasopressin? Do we titrate it? fixed dose, okay? And then what happens? What do? You go up on norepinephrine. You reach 1 mic per kg per minute. What do? You add another one. Like what? You have a choice between epinephrine and phenylephrine. So what do you want to do? And Dr. Shakur just said that he doesn't like phenylephrine. Okay, so epinephrine. So norepinephrine, vasopressin, epinephrine. Okay, how high do you go on the dosages? It's been looked at. If you have a low SOFA score, as high as you can, even, there's no limit. 1.5, 2 mics per kg. If the SOFA score is low, outcome is better. If the SOFA score is high, going higher than 1.5 is not associated with it. And you won't know actually, just you can increase it. Usually I don't go above 1.5 of each norepinephrine and epinephrine. Now de-escalation. Now let's say that we reach epinephrine and we need to de-escalate. The first one we take off, epinephrine. Second one, go down on the levo. You reach levo at 0.2. What do? You stop vasopressin first or norepi? Okay, so they looked at that. Actually, this is retrospective studies showing that if you stop vasopressin first, the chance of rebound hypotension is higher. So we recommend stopping norepinephrine all the way and then vasopressin. Not a lot of places do this, but this is based on retrospective data. That's very strong. This is only they looked at those patients with organ, meaning that if the injury was not deep enough to cause organ failure, well, going up on the vasopressors may still be beneficial. But if it already caused dysfunction and failure of different organs, it's actually the score that looked at 12 or more with the SOFA, those patients did not do well, whether you go up on the levofed or not. But in general, mortality, the higher the vasopressor you have, the worse outcome in general. If you still have the organs are function, you need to continue doing this. Patient is responding to you. He's not worsening. You're welcome. Thank you.